It's not very
Good morning, Pandian.
Good morning, good morning, sir.
Good morning, good morning.
Good morning.
Good morning, everyone. Today, Sonu will be presenting the case and it will be moderated by Professor Radhakrishna, Professor Deepak Govil, and Professor Raj Pandian. It's all yours. You can take over now.
Yeah, it's nice to have two eminent coloproctologists here, so I'll be a spectator. Govil, yeah.
Yeah, I think we can start, Sonu.
Yeah. Is my screen visible, sir?
Yeah.
Is my screen visible? Am I
Yeah,
audible?
yeah. It is
You
visible.
can start here.
Yeah. So, good morning, everyone. So, today I have a 48-year-old friend of Telangana who presented with chief complaints of altered bowel habits since 2 months and bleeding per rectum since 15 days. Coming to the history of presenting illness, she was apparently all right about 2 months back when she noticed decreased frequency of stool, for which she needed to take daily laxatives. I also wish to know whether there was any progressive worsening. How's the stool consistency right now? Was there any straining, any manual evacuation history, any history of passage of mucus? She also had complaints of abdominal fullness and bloating since 1 month. She later noticed intermittent episodes of painless bleeding by rectum, bright blood in color, not associated with any blood clots, scanty in quantity, both during defecation and spontaneously, as well as staining her undergarments since 15 days. There is history of sense of incomplete evacuation of stools needed repeated visit to lavatory. History of any loss of appetite was also present. Coming to the negative history, no history of any abdominal pain, loose stool, any postal dizziness, syncope, blood transfusion, no history of pain during defecation, urgency, or incontinence. There is no history of any significant weight loss, mass protruding per rectum, UGA bleed, vomiting, fever, icterus, or any other mass palpable in the abdomen or swelling in the abdomen. Coming to the past history, she's a known case of hypertensive on regular medication. There was no history of previous surgeries in the past with no similar complaints in the past. Family history, there was no significant history of any malignancy or TB in the family. She takes mixed diet. There is no addiction. Sleep and appetite were normal. Bladder habits are normal and regular. I also wish to know the menstrual and obstetric history. So to summarize my history, this is a 48-year-old female with no comorbidities who presented with 2 months history of constipation, bloating, and sense of incomplete evacuation. She has developed passage of fresh blood per rectum for the past 2 weeks and gives history of loss of appetite.
Okay, Sonu. So, on this history, the points
from this,
which you asked in addition, the points you've asked in addition, just explain why you've asked those points specifically.
Okay. Usually, in case of a malignant growth or any growth per se, the constipation usually is progressive, will require more laxative usage. I wish to know the consistency, basically whether was there any history of spurious diarrhea. So history of straining and manual evacuation, usually in patients with chronic constipation, they usually have history of manual evacuation or straining. So I wish to basically quantify my, the intensity of the constipation I wish to know. And passage of mucus is commonly associated with a lot of colorectal anomalies. So just I wish to have a basic idea of what is the exact contents in which except mucus passage or blood passage. Then as well as I also wish to know, was there any history of tenesmus? She gives history of incomplete evacuation with repeated visit to lavatory, but I also wish to know tenesmus history.
Okay.
And in my negative history, I wish to know.
So if I can interrupt, you have emphasized on the history of bloating and fullness of abdomen. What does that mean?
So
Does it mean something?
Yeah, there could be an element of subacute intestinal obstruction for this patient, sir. That is why in negative history, I wish to know about whether there was any history of vomiting, nausea, colicky abdominal pain, which
Actually, the significance of that in case if the patient has subacute bowel obstruction.
So in that condition, sir, if it is a malignant growth or a growth per se, it is almost occluded the lumen, or in any sense there is an obstruction. So it has become a symptomatic disease, and rather than it would take precedence in the management protocol, sir. Or it's a prolonged disease.
I'll also keep in mind, although not uncommonly, could be ascites or could be some deposit of small bowel. Some sort of advanced disease is another thing I'll keep in mind when you emphasize on fullness and bloating.
Yes,
yeah, carry on. Negative history.
So in negative history, almost all things are there, except I wish to know a bit more about whether she has any back pain or respiratory complaint, just to rule out whether there was any history suggestive of any metastasis. In past history, actually, I'm not sure whether there's a error in the PPT or there is a line of similar complaints in the past. Whether it is no similar complaints or similar complaints, I'm not very sure. Because if it's similar complaints in the past, it do become very significant. So that is the only question I have.
What previous surgery are you thinking of with relevance to this condition?
Relevance to this condition. One thing, sir, whether she had any previous colorectal surgery per se, any history of any prolapse, any history of any prolapse in the past, any history of any anorectal diseases, hemorrhoidal disease, fissures, sphincterotomies.
What is hemorrhoids got to do with this?
Whether she had developed any anal stricture or
a certain percentage of these patients, initially they start with the hemorrhoidectomy elsewhere. And when a pre-op colonoscopy is not done for hemorrhoids, and then they'll come. That could be a thing. One. And two is sometimes after a bottom surgery, the sphincter becomes lax and weak. Then you have an issue of subsequent planning. So when you're talking about similar history, previous surgery should based on bottom surgery rather than prolapse or colorectal. Some sort of bottom surgery, mostly hemorrhoids. Yeah. Carry on.
Why is menstrual obstetrics important?
Yeah. So no.
I didn't get you, sir. Sorry.
So we are in only history. So
Yes,
here is a young patient, probably 48 years. She has come to your the bleeding PR and altered bowel habit. That's all.
Yes, sir.
So what is your differential diagnosis in your mind? Straight away, you are talking to malignancy and everybody accepted.
So considering
You
so
are
she
in
has,
a OPD. Patients come to your OPD. She is not in the casualty.
yes, sir.
What do you
Uh,
think? Directly you think of malignancy, or you will rule out some benign condition, and why you put straight away CA rectum, and you are talking about the obstruction. If you are thinking of obstruction by malignancy, which part will produce obstruction? You can't put a CA rectum. So left-sided colonic malignancy, you can put okay. Understand? So
yes, sir.
straight away, you can't go with a diagnosis or with the history alone, isn't it? So now can you
Yes,
see
sir.
which CA rectum is presenting with obstruction? How many cases you have seen? First of
Only
all, you have to rule out
rectosigmoid
malignancy.
abdominally.
First of all, you rule out, think of benign condition, but always you will keep a malignancy in my mind. That is the thing you have to tell. You have a significant weight loss is there. You have not mentioned about that. In the history, you can ask, no?
No, it was not mentioned.
Then you
Yes,
have
sir.
to tell that. So there is no
It was not
significant weight loss is
mentioned.
there.
Only loss of
Loss
appetite was
of
given, sir.
appetite. Yeah, you should ask. I want to elicit all this history, how much is having, but most of the collateral will not have a significant loss of appetite and loss of weight. Loss of weight may be there,
Yes,
but loss of appetite will not be there. Okay, but most of them, they may not have a significant weight, but closely follow up, yes, they can tell you, but that history you have to elicit. So what is the commonest cause of bleeding PR in any patient?
usually hemorrhoidal disease, fissures.
Then common is common, no?
These
That
two are the most
Dr.
common as benign.
Radhakrishna straight away he told many patients will be, most of the patients, they would have undergone some hemorrhoid surgery or some bottom surgery few months before, but they will not relieved of symptoms because all these patients, they will go some sort of, because of the constipation within the 2 months, they would have developed grade 1 or grade 2, like hemorrhoids they will do, and they will have the symptoms, isn't it?
Yes, sir.
So why you don't think of inflammatory bowel disease, IBD at all? And why you are putting it
So there was
solitary
no.
rectal syndrome? What is the
I've given
symptoms
a
like that
differential
you?
as a.
Yeah, can you show your different?
Yeah, my differential is either a carcinoma or a polyp or a solitary rectal ulcer syndromes.
Rectal ulcer.
IBD, considering the age, this is a very short duration. There is no history of abdominal pain, loose stools. Um,
This is the
Considering
typical
all this, I
age
didn't.
group, and this is typical symptoms of IBD, man. Maybe first time also
Yes.
you can develop. Okay, continuous bleeding, altered bowel habits. Only thing they are not having, as I said, that bloating sensation may be there. There may be some pain may be there. Not all the patient. Okay, so you have to keep in mind the IBD and left-sided colonic malignancy. What the symptoms says. So unless you examine, then we can't go to a rectal lesion directly. Unless then you may know the diagnosis before itself. Okay. So
Even,
all the benign conditions you should keep in mind. Okay.
yeah,
Yes, sir.
Okay.
I think it's very important, as Raj said, hemorrhoids and other things are the commonest things you will think of when such a patient comes to you in the OPD. You don't think of a rectal malignancy, especially there's no history of weight loss, which is mentioned. And you have to consider hemorrhoids and benign conditions before. Solitary rectal ulcer syndrome, uh, why do you consider that? There's no history of any chronic constipation, no?
There was no long. Ideally, it should have a long history of
Yes.
evacuation, but uh, consider. I just considering
Solitary
it.
rectal ulcer syndrome is not a clinical diagnosis. Okay. So
Yes,
you have to do some investigation. Then only you can come to a diagnosis. It should be a chronic history will be there, chronic constipation there. There may be associated partial full thickness rectal flaws may be there. Okay. And there will be pain while passing motion. Okay.
So, no, before we move on, how did you localize the disease to the rectum with the history? Why can't it be higher above? What
it
symptom
could
does
be
it
left
say that
colonic
is?
malignancies also, sir.
No, no, but why do you say it's rectal? On what basis? You have any history suggesting it's rectal and not sigmoid or left colon?
Uh,
or anywhere else?
Sir, in upper, it was fresh bleeding per rectum. So, bit more upper lesions would have usually mixed with stools, altered color. I agree that there is no history of any tenesmus. So, could be a left colonic also, but considering the history of incomplete evacuation with passage of fresh blood per rectum for past 2 weeks, if I'm considering a lesion other than the benign lesion, I would consider it as a rectal also. I agree that there is a possibility for a left-sided colonic lesions too. So,
Especially with the
if they-
symptoms of bloating, etc. Okay, carry on.
So coming to the general examinations, the patient is conscious, cooperative with a BMI of 21.37. She's well built and nourished with vitals are stable. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. She has an ECOG performance status of 1 with breath holding time of 35 seconds. I would like to know, examine her oral cavity and skin, any significant skin lesion. In abdomen inspection, abdomen is flat with umbilicus central in position inverted. All quadrants of abdomen are moving equally with respiration. There was no scar, visible peristalsis or nodules.
Please just tell us important positive finding.
My general examination, abdominal examination are otherwise normal, sir. There was no significant finding in any of my abdominal examination. Coming to the digital rectal examination, the perianal skin was normal. There was normal skin tone. There was a firm growth palpable from 2 to 6 o'clock position at about 6 centimeters from the anal verge. It was non-tender, does not bleed on touch. The upper border was extent of the growth could not be made out. Glove was stained with blackish stools. Proctoscopy was not done, sir. Other
Go to
system
the previous
examination is
slide.
essentially
Go
normal.
to the slide. Previous.
Previous.
So in the palpation, you want to see only the inguinal nodes. You
No,
don't
sir.
want to see which other is more important.
No, I've given my general examination, generalized lymphadenopathy, sir. Here specifically.
Generalized lymphadenopathy is not there. Then in palpation, you want to palpate which area?
Abdominal examination, sir. Along with
No,
abdominal
in the
examination.
left, see, left supraclavicular, you have to mention. If it is not there, there is no left supraclavicular lymph node. Okay. That is standard only. It is a part of abdominal examination.
Yes, sir.
Okay.
Yes, sir.
You have diagnosed everything, and if you palpate a left suprac lymph node, then what it indicates?
It has become a metastatic disease, sir.
Yeah. Okay.
Yes, sir.
So always in abdominal examination, whatever you have feeling, you have to say that the left suprac lymph node is not palpable or it is free. Okay.
Yes, sir.
Any
Inguinal, why
ascites?
you want to mention inguinal nodes? What is the importance of in this case?
The lower rectal malignancies can present with inguinal lymphadenopathy, sir.
Okay. So you are thinking of CA rectum. So what? Wow. So inguinal positive, what will you do?
So,
What is the thing? What are you thinking?
Usually, sir, if lower rectal malignancy is present with inguinal lymph node, it can be either due to proximal obstruction in the lymphatic flow or through the inferior epigastric or internal iliac nodes. NCCN currently considered it as a metastatic disease, but there are studies which recommend curative resection and chemoradiation for even for inguinal lymph node positive diseases. So I just wanted to.
No. So at present, we are only examining. So in
Yes,
that case, you can think, okay, it could be a
advanced disease.
anorectal malignancy.
Yes,
If it is
anorectal.
anal canal, you can go to the inguinal. Okay.
Yes, sir.
Okay. Okay.
Any
Continue.
tests you have not mentioned clinically?
Yes, sir.
Clinically, in our palpation and other examination, you haven't mentioned any ascites.
Oh, yes.
Yeah, is it important? So you have to point
Very
out
important. Yes.
important negative things also while you are presenting, no?
Yes, sir.
Yeah. Okay. Okay, go ahead.
Okay.
Yeah, digital rectal examination.
Yes.
Tell us about the digital rectal examination. Do you think it is complete or anything else you would like to do in such a situation?
One is to begin with, in any digital examination, I wish to know the local examination, any skin lesions or nodules, perianal skin tone, perianal skin, whether the sphincter tone, the squeeze pressure is normal. Considering the lesion, as it is written here, it is firm growth from 2 o'clock to 6 o'clock position, 6 centimeter from the anal verge. It is not in the upper border, is not palpable. I wish to know the fixity of the lesion too, and the glove stained with blackish stools. Ideally, a proctoscopy should also have been done, but
Okay.
Okay.
In the history, it was mentioned that there was bleeding without knowledge also. There was straining of the clothes also in garments.
yes, sir.
What does that mean?
Usually that comes from probable hemorrhoidal disease as a possibility, sir, but as seen in my, I mean, I have not done a proctoscopy in this patient, so hemorrhoids cannot be ruled out. Any polypoidal lesions or any malignancies can also produce a bit amount of staining in patients, but commonly it is seen in hemorrhoidal disease, sir, or fissure.
What are the other things? Normal skin sphincter tone. What he is asking is, in case a patient is having incontinence with this finding, so what is going in your
Okay,
mind?
yes. So with these findings, if there is a incontinence, one the sphincter may be involved. So if
Yeah,
you're
yeah.
planning for a
The upper part
future
of sphincter, it
treatment,
is 6 centimeter.
Yeah.
Okay. Only thing
yes,
is
sir.
6 centimeters are unlikely the sphincter is involved in this case. Okay.
Yes,
Okay.
yes.
Yeah.
Next slide.
Other system examination was essentially normal, sir. A pervaginal examination was not done for this patient. Um, uh, oth- um, s- um, so to summarize, sir, my patient is a 48-year-old female with no comorbid illnesses and ECOG status of 1, presents with history of 2 months history of constipation and sensation of incomplete evacuation with bleeding PR. Digital examination revealed a firm growth 6 centimeters from the anal verge, 2 to 6 o'clock position, which does not bleed on touch, and upper border is not palpable. General and other abdominal examination is otherwise unremarkable, sir.
So per vaginal examination, what you are looking for this in this particular case? Why it is important?
So a patient with constipation history, especially female, we should rule out any rectocele, or if at all a growth is there, whether there is any infiltration
Yeah,
in the
yeah.
anal wall,
This is
any
the main thing.
fistula.
So you have already diagnosed it. There is a lesion there. There
Yes,
is
sir.
a tumor there, firm. So mostly it is a malignancy. So, but it is 2 to 6 o'clock position. So if it is
Yes, sir.
anterior, more possibility. If it is locally advanced, whether it is infiltrating the vagina or not, we can
Yes, sir.
look.
Yes,
Okay.
yes, yes, sir.
Okay. So how will you proceed? So here is a patient is sitting in front of you in the OPD. How will you confirm? You have already seen, mostly have come to a diagnosis. How will you confirm your diagnosis and how will you establish your diagnosis?
So initially, I would like to do investigations to establish my confirm my diagnosis, sir. As part of my initial evaluation, I wish to prime the patient for a colonoscopy and biopsy, sir. Along with that, baseline blood investigation, as she's having bleeding per rectum, I wish to know her hemoglobin status, PTINR, platelet, and
First,
as
yeah. First, directly you can't say colonoscopy. You are thinking of subacute obstruction also, isn't it? Then how
yes,
can you prepare the patient for colonoscopy? Then you are suspecting
yes,
obstruction. But here you don't know. First, you said
yes.
patient is having bleeding PR for the past 2 months. So you would like to know the status, blood test,
Hemoglobin
particularly
status, yes, sir.
hemoglobin. If hemoglobin is only
Yes,
6, then how can you directly take the patient for colonoscopy? So
yes,
basic investigation and specific investigation. Basic investigation you have to do for all patients to get a fitness for any other investigation or surgery. Okay. So basic
yes, sir.
general, that is general investigation. Okay. Then only you can
Yes,
order.
sir.
Okay.
The patient is having a hemoglobin of 13 with a total count of 10,000, platelet of 3.46. It's essentially normal, sir. I will also like to baseline creatinine, because as I'm clinically suspicious of a malignancy, I wish to get a imaging done. So creatinine is also essentially normal. To know the general nutritional status, I would like to know LFT with albumin levels. If possible, PTINR also, which is also essentially normal in this case. Once these basic investigations are available with me, I would proceed with the as part of my as part of my extension of my clinical examination. Yes, I would also like to get an ultrasound abdomen done in the meantime, but I would plan for a colonoscopy with biopsy. So, USC abdomen, the liver appears
So
normal.
what will you look for ultrasonogram in this case?
So
What
in
do you
this
want? Yes.
patients, first I would like to know whether there is any distant metastasis, liver is normal, whether there is a condition of liver, any metastatic deposits, with the presence of ascites, any abdominal lymph nodes which are prominent. To an extent, abdominally dilated bowel loops can also be detected in ultrasound, sir. Yeah, any other solid mass lesions, if possible, as this is a female, her ovarian status, uterine status. Yeah, so these are the things which I'm looking for in my ultrasounds.
Okay. So how will you confirm your diagnosis?
I will.
Correctly, you are saying you have felt a lesion. The patient in the OPD, how far you will send the patient, then you plan for colonoscopy, or immediately you take a biopsy.
So, as initially said, sir, okay, we could try if it was a bit more lower lesion, I would try for a proctoscopy and
So
biopsy if it is
how do you
feasible.
investigate such patient in your center? Where are you
In our
from?
center, we usually send for colonoscopy, sir. We
You
send for
should send for
full-length
colonoscopy.
colonoscopy with biopsy, sir.
Okay. If the patient scope would not be passed beyond the tumor.
So if the normal scope is not passing, we could try for a pediatric scope or an endoscope to be passed. If that is also not feasible, we just take a biopsy and come out, sir, and rely on our CT imaging to plan for further investigations, sir. Plan for further management.
Would you not do a proctoscopy biopsy in the OPD
Yeah.
itself? Would you
So-
wait for a colonoscopy, bowel preparation, and all? Wouldn't you like to speed and things up? Because, a rectal lesion can easily be biopsied, a good chunk with a proctoscope rather than a colonoscope.
Yes, sir, it could. I mean, in our institution, generally, we prefer for a colonoscopy biopsy. So, for one thing, we could examine the entire bowel if possible. I mean, if it is
No, that
feasible.
is there. That is a part of the story. But, isn't it a protocol that you have a lesion palpable with your finger, that you do a proctoscope and do a biopsy in the OPD itself rather than wait for a longer period of time? I mean, it's ideal to do that if that
Yes.
facility is available. Yeah, carry on.
Yeah. So always, if the palpable tumor, you do the biopsy and you can plan for colonoscopy because you want to rule out any
Toxin.
associated lesion anywhere in the colon.
Yes, sir.
So always, even if it is there, you can, as you said, you can do a proctoscopy or even a rigid sigmoidoscopy or a flexible sigmoidoscopy. Take a biopsy because biopsy will take another 3 to 5 days. By that time, you can plan for other things. The patient has come, you want to confirm, as you said, if it is palpable, take through proctoscopy or through a sigmoidoscopy, take a biopsy. Then you prepare the patient for colonoscopy if patient is not having obstructive lesion. Okay.
Yes,
So
sir.
now for the confirmation, as early as possible, you have to confirm because you are thinking of malignancy. If you wait for more days, then you are the one before going for metastasis. Okay, nobody knows. Next week also she can develop metastasis. Then
Yes.
you have to, once you confirm, then you have to establish the diagnosis whether patient will come for surgery or not. Okay. So colonoscopy finding reached.
Rectum shows a large polypoidal lesion with central umbilication of size 3 cross 3 centimeter, noted at 5 centimeter from the anal verge. The other sigmoid descending, transverse ascending, and cecum and terminalium appears to be normal.
Okay.
What
So
does
what else you want to
umbilication
do?
suggest?
Uh,
Is it characteristic of any particular lesion?
not sure, sir. Sometimes villous adenoma can present with an umbilication, sir. But,
Why will villous adenoma have an umbilication in the center?
I'm not sure of the reason, sir.
It's a sort of an ulcerated lesion. So what is the color of the lesion? Are you interested in it?
Color.
What lesions are colored in the in case?
So, but, I'm not very sure, sir. I mean, color.
What
Is
are
there
the
any
other
color?
lesions? What he's asking, what are the other lesions you will think you keep in mind other than carcinoma if you see a lesion like this in the rectum?
Any other polyps, sir? Then
Polyp means polypoid lesion. This is not a
Polyp.
polyp. We are not talking about polyp. Lesion, polypoid lesion. Okay. Polyp also mostly it is adenocarcinoma. Other than adenocarcinoma, is asking. What
any
are the other lesions
hematomatous
to keep in
lesions, sir?
mind?
Any adenomatous or hematomatous lesions?
What, man? Everything will come.
Sibu, you are, Sonu, you are only with the polyp and malignancy. You are not seeing anything else.
Yes.
Do you find any other lesions in the rectum like this, which the treatment protocol might be different?
Sir, gist can be appearing, sir.
Yeah.
Submucosal lesions.
Yeah. Gist
Yes.
can present like this, umbilication like in stomach, it can present in the rectum also.
Yes.
It can be a malignant melanoma also can present. That's why he's asking color of the lesion.
Okay, sir.
Okay, sir. We have,
Carry
okay. So now how do
Now,
you want
actually, when there are two things. One, you said the finger stall has got black color, dark colored motion. That you had explained that. And two is she also has a history of similar complaints in the past. I mean, what could those be? These two, if you can explain before we go further.
So that similar complaints in the past, I'm not very sure, sir. Why I mean, the history was not elaborate, it was not given to
No,
me.
you should
So,
take elaborate. See, suppose a patient had bleeding PR off and on for quite some time and got a pathology now. What could that be? A lady.
pardon, sir, I get you.
No, she has a chronic history of bleeding per rectum, multiple episodes, and at this moment developed this particular complaint. What could that be? Now, in other words, did she harbor any bowel disease which led to this?
Okay.
Inflammatory bowel diseases can present
IBD
like
can
this.
present. Yes, sir.
Polyposis colic can present like
Yes,
this.
sir.
And regarding dark colored motion on the finger stall, what does that mean?
So usually a darker color comes from an upper, more proximal lesion, sir. So if the lesion is bleeding and retaining posteriorly, very unlikely for that. So I'm not sure whether how much relevant it is to this particular lesion. But if
And we
it's
have to keep
bleeding,
that in mind
yes,
because
sir.
we should keep that in mind that the patient could have some other like polypus coli, for instance, can have polyps in small bowel. And also, actually, sometimes some blood leaked into the rectum has been there overnight can also become something like this. Anyway, carry on. What does the colonoscopy show? Is just a rectal lesion, right?
Yes, sir.
Rest is normal. What next?
So what next? You have done a colonoscopy, you want to know what is the pathology report, or meanwhile you want investigation further to establish a diagnosis?
Yes, sir. Along with the colonoscopy, I'll send for a biopsy, sir. In the meanwhile, I would like to plan for imaging investigation, sir, as well as CEA levels, baseline CEA levels, and imaging investigation, sir.
So baselines here, while asking for the blood investigation in general, then you will be asking for the CA as well.
Yes, sir.
Okay, so you like to know the CA. Yes, CA is 22.9. So what will you do now?
The CEA is
So
elevated.
what imaging investigation will ask? What is the imaging investigation of choice for a CA rectum?
MRI pelvis, sir.
Okay, so MRI pelvis will know what stage, what
T
are the
stage,
stages?
the
T
T
stage
stage
and
and N stage
N
can
stage. Okay.
clearly. Yes, sir.
For M stage, which one you want to know?
I would like to get a CCT abdomen with a CCT CT thorax with a CCT abdomen, sir.
Why? Because
Uh,
you have already CEA is 22.9. Do you think that is normal?
no,
What is the
sir.
normal level of CEA?
In less than 5, sir.
Okay. So now how many times it is higher?
4 times, sir.
Okay. What is going in your mind?
This could be a locally advanced or a metastatic disease, sir. I mean, we have to
Okay.
keep that in mind.
For that, would
Okay.
we like to do any other tests which Raj is hinting at?
Generally, sir, our institutional protocol is to take a CECT abdomen first, sir. But if we are suspecting a metastatic disease upfront, we could try for a PET-CT, but generally we go for an MRI pelvis with CECT abdomen and a CT thorax, sir.
See, that is a common. But if CE is normal, what you are told is correct. But already CE is high. So if you are suspecting, for in this case, you are suspecting metastasis or not,
Yes, I would be suspecting, sir.
then you should ask for a PET-CT rather than directly going for a. So why you want to subject the patient for radiation twice? If
Yes,
PET-CT is going to give all the information what you need by the CT scan abdomen and chest. Okay, so this is the only indication where you ask for a PET-CT whenever there is a increased CEA. So instead of CT scan abdomen thorax, you can directly call for a whole body PET-CT.
yes, sir.
Okay, so you can avoid CT. Otherwise, there is no role for PET-CT if the CE is normal in colorectal surgery,
Yes,
unless you are suspecting metastasis. Okay.
yes, sir.
Okay.
Sonu, you can always explain that this CA may be due to locally advanced disease. If this CA is during follow-up,
Yeah,
PET-CT,
we'll
there's
plan
no
for a
option.
PET-CT.
Before the primary treatment has happened, this CA can still be due to local, and if you are not mentioning PET-CT, then you're not penalized. PET-CT comes in if this CA is seen in the follow-up.
It's
Yeah, if it is could very well be, but if the local imaging does not show local extension, then it should be a possible distant metastasis.
Yes, sir.
Yeah, carry on.
We want to know what now?
I will like to begin with, I wish to know about the MRI pelvis status, sir.
So the
Uh,
MRI pelvis.
I'm not able to.
So what are the important points you will look in the MRI? Tell me 1, 2, 3, 4, 5. 5 points for
So
a
first,
CA rectum.
the location of the tumor, sir, its relationship with the peritoneal reflection as well as to the levator ani complex, the T stage, the depth of invasion, the nodal status, the MRF status, the CRM or MRF status. Then the fifth one would be other pelvic pathology. I mean, yeah, this is what I will
No,
check, sir.
important 2 things you have not mentioned.
Extravascular lymph, vascular.
EMVI,
EMVI.
Yes, sir.
extramural venous invasion. Yes. Another thing,
T stage, N stage.
now the new concept, the tumor deposits.
Deposits.
So
Yes.
you should know the tumor deposits.
Yes, sir.
Okay. So if tumor deposits there, that is very, very important. You have to see. Okay.
Yes, sir.
Okay. Let me see the findings.
Yeah, tell us.
What does it show?
So in the sagittal section, sir, I could see a lesion.
Can you show the axial as well?
Yes, sir.
Is there any breach in the rectum?
Uh, I'm doubtful at this point. So, I mean, at the right 11 o'clock position, whether that's a breach. But other than that,
The lymph nodes?
Just keep telling us your interpretation and your
okay.
about findings.
Yeah.
So this is a T2 weighted image, sir. There is a circumference lower rectum, possibly below the peritoneal reflection, with the lower margin is the levator ana complex does not appears to be involved. The CRM appears to be intact to me, sir. It's extending from left side, left posterior aspect.
Yeah, Sonu, you should be more thorough while presenting these rectal images. You should be very spontaneous. You're sounding doubtful, and I mean, you're relying on the examiners to decide on what is there in the radio. You should be confident. You have to get into the habit of commenting on imaging, very spontaneously. It's very important.
Yes, sir.
Yeah. Okay. Move on.
There also appears to be a lymph node present at this level. So,
Okay. So, what stage does it attribute to?
One node or many lymph nodes?
yes, sir.
One lymph node or other lymph nodes are also there?
There are 3 lymph nodes. 2 lymph nodes. And this one lymph node appears to be clinically very significant. And
So how will you signify the lymph nodes in the MRI?
so MRI, any lymph node more than 8 mm in short axis with irregular borders and heterogeneous intensities is considered to be significant or probably neoplastic lymph nodes.
So if there is a 5 mm lymph node with heterogeneous, irregular.
The size actually is a secondary parameter. So more of the irregular border and the heterogeneous uptake is more, heterogeneous feature is more important. So.
Yeah.
So how are you staging this tumor based on imaging?
So I would stage it as a T2N1 disease. Sir.
T2.
T2
You
but
said
T3.
there is
Sir.
a likely breach there, close in the upper aspect.
Yeah.
Right, a
Then how can
voluminous
you say?
disease.
So what do you mean by T1? What do you mean by T2? What do you mean by T3?
This could be a T2 but T3 disease. I'm not very sure about the T status in this.
So what is T1? What is T2? What is T3 and T4?
So one is T1 is submucosal involvement. So T2 is involved. T3 is when
T2 is what?
sorry,
T2
is submucosal involvement, sir.
T2 is submucosal.
Sorry, I got confused.
What, man?
T1
T2 is muscle.
What is stage 3?
Stage 3 is when the muscularis propria is breached, sir.
Okay, so the muscularis propria beyond the muscularis up to
Yes.
muscle involvement, it is a T2. So beyond
Yes.
muscularis involving the serosal, then it is a T3. So
Yes.
already we are suspecting there in this lesion. So
What
we
is
should
T3
be,
A, B, C?
and it is 3.
So it depends on the depth of invasion, sir. 5 mm, 5 to 15 mm, more than 15 mm, sir.
Yes, that is in the MRI mainly. Okay.
Yes.
Okay. Okay, let me see the MRI report. So what else you told you want to know EMVA, if there are any tumor deposits there? Okay.
Yes, sir. Yes, sir.
So why you want to know all these things? This EMVA, CRM, tumor deposits, everything. Why is it important?
So all this will help me in planning my disease. If it's an early disease, I would when the management protocol changes with early disease. I mean, if EMVI is involved or is if there are features of advanced disease or
Have
CRM
you
is
heard
threatened.
about good, bad, and ugly tumors?
Yes, sir.
What is good tumor, what is bad, what is ugly. So all these are characterized or separated or staged according to the MRI. So just read the MRI report.
There's a hemicircumferential T2 intermediate signal intensity growth noted involving the mid-rectum with perirectal fat standing and shows restricted diffusion, measuring 3.6 centimeter in length. Longitudinal extents corresponds to the lower margin of S3 superiorly and 1% coccygeal level inferiorly. Lower extent
Okay,
of
it's T3A, N1A, right? What next?
yes, sir. So it's a T3A N1 disease, sir. I will also like to get the CCT abdomen of this patient
For
or
what?
PET CT, depending on the metastatic workup.
Now, it should be clear why you want to do CT abdomen and why you want to do PET CT. No.
So as our institutional protocol, we usually get CCT abdomen, sir, because we are more comfortable with reading CCT abdomen. But as if you're
So CCT
high
abdomen you're doing
suspicion,
for what?
one is for liver, knowing the liver status, any other metastatic, any nodal involvement, as well as we also look at the localized tumor status also, just for the visual interpretation.
How do
And
you
then
image the chest?
usually we get a CT thorax, sir, along with the CCT abdomen, sir.
What are the reports of these two?
Not,
So why you did PET CT? What is your justification?
so a PET CT is indicated when if a CCT cannot be done, any IV contrast is allergic, or if there are any
As Raj
inconsistency
was
signs.
saying, if you're doing a PET CT, why do you want to do a chest CT and abdominal CT prior to PET
So
CT?
one is the CT done along with PET CT is not of an adequate quality. So assessment
No, it's not.
with
This is not a correct answer for this question. That's already we have discussed. So
one is
whenever
CA
the
level,
CE
sir.
is more, when the CE is more, then you ask for a PET CT. That is the
Yes.
only reason why you are asking PET CT. And in this case, CE is more, so you have to tell, so I would like to have a PET CT rather than CT scan abdomen and chest. Okay, this
Yes,
is the answer you have to give in the exam.
There's no
Because
point
there is
in
no
repeating both these
point
tests.
giving extra. We'll have a CT scan with the PET CT. PET CT will give all the information. You only have to read, okay? Or with the help
Yes.
of radiologist, all the information what you want, it be in the CT as well as in the PET CT. Okay.
Yes.
So,
Yes.
but if regularly, yes, usually we will not ask for a PET CT unless there is increased CEA. Otherwise, there is no role for PET CT in a CA rectum. But usually
Yes.
everybody will be doing CT scan abdomen just to look for the metastasis. Here, because
Yes,
increase CEA, we want to rule out the whole body PET CT to look for any metastasis. Okay.
What is the histopath in this patient? Okay, and I'll tell you about a case I had in my exam, MCS exam. The biopsy has come as non-specific colitis.
yes, sir.
What will I do?
But with this picture, sir, I'll go for a repeat biopsy, sir. The patient is
Repeat
not
biopsy
obstructed or any
also comes as non-specific colitis.
well biopsy, a deeper.
Yeah, because I had a situation where the examiners went on and on. They just want to see whether I would like to do surgery without biopsy. Would you? Everything is classical.
So
Radiology is classical. Clinical symptom palpability is classical. Then when if the histopath is you're not hitting the right area, then what should I do?
for this disease per se, sir, for this patient per se, if I'm not getting a biopsy, the imaging itself shows that it's a T3A N1 disease. So outright surgery is not something I would recommend. But for a neoadjuvant therapy, I would require a biopsy, sir. So I think we
The
can go
answer
for
is you're
multiple
not going to
trials.
do anything definitive without a biopsy, whether you do a neoadjuvant treatment or whether you're surgery, because that's a rectum and so many things involved. It's a lady. I mean, that's what they have expected, and that's what I answered, and that's what I passed actually. Anyway, what is your plan now for this patient?
Sir, I would like to have a multidisciplinary team, sir, discuss with the patient the treatment option. And as this is a T3A N1 disease, sir, I would plan for a neoadjuvant chemoradiotherapy, sir. And then restage the disease and then plan for a surgical repair depending on the response, sir.
You've gone too far actually. Now, step by step.
So I asked you what is good tumor, what is bad, what is
Yeah.
ugly. So what do you think? It is a good tumor or bad tumor or ugly tumor? Can you read the MRI report again?
Just the report. Yeah.
What are the things you want to know this?
One is the extent of the tumor, sir. It's below the anterior peritoneal reflection, does not involve the peritoneum. There is extramural spread of 1 mm, sir. The CRM is not involved. The extramural vascular invasion is negative, sir. There is no invasion of puborectalis or levator muscles. There is no surrounding infiltration. There is a tiny solitary suspicious nodule of 5 mm in short axis in the
Don't
presacral region.
repeat all these things. Just tell us on the basis of these findings, where would you put this tumor in?
This is a good tumor, sir.
What you? Another important point apart from MRI to add to that is
Uh,
So it is not a good tumor, man. So good tumor means if it is T3A with
yes, definitely.
not obvious lymph node or just less than 5 mm lymph node, with no that extramural spread is there positive, no EMA positive, CRM not involved, yes.
Yes, sir.
So here you have a positive lymph nodes and extramural spread is there. So you should make as a bad tumor. Though CRM is not involved, it is very close. What do you mean by CRM not involved?
So
When
not
will you say
involved
it is
is
involved? When will you say it is involved?
so less than 1 mm is involved, sir. Less than 2 mm is
1
threatened.
mm of what? 1 mm of what? The lesion or even the
From
lymph
the
node? Yeah, if it is a big lymph node, it is
even the
close to CRM, that is also, we can say
that
it
is
is
also
a,
involved.
yes, yes. So all these things you should keep in mind. So that's why you want to go for a neoadjuvant CTRT. Okay.
also
Okay.
in the biopsy, is there anything like if there's a signet ring tumor, signet ring cell tumor, will it make things different?
Yes, a signet cell tumor or poorly cohesive tumor with poor differentiation, that would suggest a bad pathology, sir. Or a mucinous component, that would be a bad biology, sir. So in those tumors also, I would prefer for a neoadjuvant therapy, sir, rather than upfront surgery.
Okay. So what will you do in this case? So you will
So I'd
put in
like
a
to
tumor
plan for a
board
near,
multi-assembly operation.
yes,
Okay.
sir.
So what is your plan?
And sir, I would like to plan for a neoadjuvant chemotherapy, sir. In our center, we actually prefer for a long course chemo RT. But as this is a T3N1 disease, short course chemo RT can also be given a trial, sir. So we prefer to go for a long course chemo RT, 50.4 gray over 28 days, sir, and then restage the disease. Then depending on the restaging findings, then plan for a further treatment, sir.
So while giving a neoadjuvant RT, you will give chemotherapy or not?
So we usually give only sensitizing chemotherapy, so with capecitabine or 5-fluorouracil. Generally, capecitabine is used here. And then,
She,
yes, as I agree that
it's
there is
not
a
a case
possibility.
for as Raj is hinting, is she a case for total neoadjuvant treatment?
She could be, sir. There's a possibility, though
The points,
the trials for total neoadjuvant is more for T3, it's for T3 and T4 diseases. We could give for a total neoadjuvant therapy
why
with
not?
induction or a consolidation chemotherapy, sir.
She's a young
Okay.
patient, locally advanced lesion,
We could plan
and
for an organ sparing, sphincter sparing.
comorbidities.
Isn't she an ideal patient for total neoadjuvant treatment?
Yeah.
Yes, sir.
Doesn't she fit in everything? Then why are you hesitating?
We could, sir.
No,
Okay.
you can say this is not a ideal tumor for a TNT because CRM is not involved. It is not an ugly tumor. Now, if it is a EME positive, tumor deposit, CRM positive, large lymph nodes are obvious, then those are the ugly tumors, which is we go for a TNT. So we don't want to have a over dose. So it is for a bad, for a good and part of the bad because None of the lymph node is more than like 8 mmR. So just less than a 5 mm only these lymph nodes they have mentioned. Okay, so clinically we are not thinking probably the reactive lymph nodes or maybe positive only after that. So this case you can go for neoadjuvant, standard neoadjuvant chemoradiotherapy, or you can wait during the interval. We are giving nowadays interval chemotherapy during the waiting period. Then after surgery, then remaining chemotherapy will give. So how long you will wait in between the surgery and the neoadjuvant CTRT? When will you take
If
him for
given
surgery?
long course CTRT, sir, long course RT,
Yeah.
we usually wait for 6 to 8 weeks, sir.
6 to 8 weeks.
On this
Okay.
patient, sorry, I just wanted to ask, any other investigation which might help you to decide whether we should go ahead with the TNT or not in this patient?
The genetic mutation studies can be done, sir, or IHC, MMR, MSI studies, as well as BRAF mutation studies can be tried, sir. If BRAF positive or MSH, we could
So
plan for
when
a
will
new
you ask for, say, are you doing MSI or not once you do the biopsy?
we usually send MSI for MMR, MSI, MMR for.
So how is going to change your management in case MSI?
So
Tell
in
me
an
in this patient.
MSI high patient, we generally plan for in our center, we plan for a Folfox regimen, sir, rather than a Capiox regimen. That's what we follow. As well as any BRAF mutation, we generally don't give any preoperative immunotherapy or any other inhibitors, but there has been trials for that. So, but we generally we don't give it. So,
No, what is I am asking is, so here is a patient comes with you, sir, I don't want any surgery. I am ready to spend whatever amount of money you ask, but without surgery, is there a possibility you can cure my disease?
So there
And
is a
you are,
possibility for a non-operative management and wait and watch policies, but it depends on my response
no,
to
no,
my
no, I
initial
am
treatment,
asking
sir.
that after doing MSI, you said MSI high. So MSI high
Yes,
has
sir.
come. What is meant by MSI high and MSI stable?
Yeah.
MMR proficient,
Uh,
MMR deficient. Tell me.
so MMR
If
is
this patient comes or
DNA.
MSI high, biopsy you have done a MSI, it is MSI high. That
Yes,
means
sir.
MMR
So MSI,
deficient.
yes, sir.
Then
In
what
those
will you?
patients, I would not recommend. I would not recommend. But we could actually try. There are trials of dostarlimab being given for patient
So not try.
to
What the
achieve
NCCN,
TNT.
recent NCCN guidelines, what it says. Have you read before this?
Dostarlimab can be given for MSI high
What
patients,
is
sir.
called? That is?
Immunotherapy.
Yes, immunotherapy.
Yeah.
So you can give immunotherapy, whatever as the daxdilimab can be given in this patient, and it can cure the disease at present. So you can ask for a direct care immunotherapy for this patient. So that is the option, but it is not widely coming. What percentage of MSI is coming in your institution? If you do have 100 patients, how many patients you have come across MSI high?
I'm not sure about the statistics as per.
Have you ever come across any even single patient MSI high?
As of now, no, sir. I mean, till during my course period, no, sir.
Yes, it's very rare, but less than 5%. Okay, what is the standard treatment? As I said, long course neoadjuvant CTRT. Okay, you are given, so you are waited for 8 weeks. Directly you will take for surgery or you will do some investigation before planning for surgery in this patient?
I would like to reevaluate my patients, sir. I would like to repeat
What?
my MRI scans with diffusion weighted imaging, with the
Okay.
MRI with diffusion weighted imaging, sir, to assess for the
So
response of the
whether
disease.
what do you want to see in this MRI?
The tumor regressions, sir. The tumor
Okay.
regressions.
So do we have a MRI, post RT MRI?
Why diffusion weighted? Why not preoperatively? You didn't specifically mention diffusion weighted imaging.
The diffusion weighted imagings are predominantly used to identify the fibrosis and the response to the neoadjuvant therapy, sir. We do T2 weighted images, but predominantly the response is assessed in diffusion weighted imaging, sir. It gives us a cellularity of the disease.
But even in preoperative, in any MRI, I think it's a good thing to do, right?
Yes, sir.
Okay.
So in this axial T2-weighted axial image, sir, I could see I can see a significant reduction in the tumor volume, sir. The previous suspected breach in that 11 o'clock area is not seen. The lymph node status, the intensity has decreased, but it still remains, sir. There are few lymph nodes, but the size is very small, sir.
So what is the what will give the regression grade?
It's a
Great.
good
MRI
response.
regression grade.
Um,
A good response.
yes, sir. It's a good response, sir.
Okay. Can we read the report?
The previously seen hemicircumferential T2 signal intensity growth involved in the rectum is replaced by significant fibrosis with fat stranding, measuring 2 centimeter. The longitudinal extents correspond to lower margin of S4, upper extent of below the peritoneal reflection. Extramural spread fibrosis is noted. The CRM is not involved. Extramural vascular invasion is negative. No significant lymph nodes seen. So no involvement of puborectal muscles, levator ani muscles, and anal sphincter complex. MRI regression score of grade of 2, sir.
What is the grading like?
Yes, sir.
What is the grading MRI?
Grade 1 is complete absence of any residual disease, only fibrosis is left, sir. Grade 2 is predominantly fibrosis with minimal disease. Grade 3 is predominantly disease with minimal fibrosis, and grade 4 is progressive or no change in the disease, sir.
Okay. So you're happy with this?
Yes, sir. The patient has responded well to my neoadjuvant therapy, sir.
So what will you advise? So patient who has not received in the interval period no chemotherapy, isn't it?
Yes, sir.
Okay. So how will you proceed after this?
So now I would like to plan for my surgery, sir. Along with this, I'll also wish to do a digital rectal examination to correctly ascertain where the level of my lesion is right now, and then plan for
Can you do a
surgical.
sigmoidoscopy also? Will you do or not?
We generally don't do it, sir. We prefer to do only a digital rectal examination, sir. For one thing, it's
So
very friable.
what make you to so what prevents you in doing sigmoidoscopy in this patient? Why?
One, it's
By
very
doing
friable, sir.
sigmoidoscopy, will you alter the disease?
Per se, no, sir.
Why? Then blindly you want to do PR and CR. That they said 7.5 centimeter the MRI says from the anal verge. Even if you do, then you say nothing is bad, isn't it?
Yes, sir.
So you want to do a sigmoidoscopy to know whether any ulcerative lesion or only scab is there.
Yes, sir.
Or only the scar is there. Okay, so because initially we thought it is a polypoidal lesion.
Yes, sir.
So you have to go and see. Then only you can compare how it has given the neoadjuvant. Okay.
Yes, sir.
Then only you can decide whether you can do a wait and watch or go for surgery. Anyway, this is MRI itself shows there is only grade 2. So this patient will go for a surgery.
Yes, sir.
Okay. So what surgery you want to do?
I would like to offer the patient the laparoscopic low anterior resection surgery, sir, with stone.
Okay, we'll ask your gynecologist to examine or not. Still, for this patient, you will ask your gynecologist to put a finger on the vagina, whether it is anything is there close to vagina. And you will, during surgery, you will ask them to guide while doing an ultra low anterior.
Yes, sir.
So that is very important you have to tell in the exam.
Yes, sir.
Okay. Okay. So what surgery you want to do? What are the difficulties you may come across? Anything you want to do before doing this surgery? Because it is like 6 centimeters of anal is there. It is the lower one-third rectal cancer. Sphincter is good, but that is subjective. Anything you objective you want to know before going for surgery? You want some evidence?
Generally, we
Are you
don't do a
doing
manometry studies or any balloon expulsion studies, but
balloon expulsion? No
yeah,
need. So to assess
manometry also
the
generally we don't practice.
Preoperatively, while counseling this patient, what will you tell? Will you, because he is
Yes.
very worried about the stoma
Yes.
or a permanent stoma. So what will you, how will
So
you?
one is that I would strongly recommend for a covering stoma, sir, because as this is a radiated field and it's an ultra low or
That
low
is
anterior
fine. But
section,
permanent stoma or
then
no stoma,
secondly,
sphincter preservation, how
yes,
will
sir.
you counsel?
For the sphincter preservation, sir, I would
At
depending
5
on the
centimeters.
as seen by
Tumor is at 5
yes, sir.
centimeters. Tumor is at 5
Yes,
centimeters.
the preoperatively pre-neoadjuvant it was at 5 centimeters. So there is a possibility for at least a partial resection of the sphincter, sir. So I would possibly warn her about the possibility that in post closure of the stoma, she may develop significant LAR syndrome, sir. But we have to reassure that it could be medically managed. I think a permanent stoma would be at this setting would be too much for this patient, sir. We should offer her a trial of sphincter preservation and then
When will you consider a permanent stoma in situ?
so you mean when will I plan for
Yeah,
a
five.
APR
See,
APR
the surgical margin you will decide on the basis of preoperative MRI or a post-neoadjuvant thing MRI. Your
So,
margins,
so
especially for
usually the mucosal margin we decide based on the margin we based on the preoperative imaging, sir. That's what we follow here, sir. But a trial of sphincter preservation, we could try for endosphincter dissection at all, if we are planning to preserve the sphincters. As she's a 48-year-old female, I think we should give a trial of an sphincter preservation, sir.
No trial and all, man. 7.5 centimeter, you have to sphincter spasm. You don't talk about
Yes, sir.
APR.
We have to
That is
preserve, sir.
number
Yes,
one.
sir.
So you have to do a anal manometry before going for surgery because you want object evidence. Of course, you have subject evidence. Sphincter stone is good and contraction is good. You have to make even post radiotherapy. So radiotherapy itself can damage the sphincter
Sphincter.
function.
Yes,
So
sir.
that is important. That's why we are waiting for 8 to 10 weeks and make sure the patient contractions coordinator sphincter tone is good, and you have to do anal manometry to have a objective evidence to the resting anal tone is good. Otherwise, post-operative, there is a more possibility. If you are doing ultra low, there will be a yes, LAR syndrome. There is high possibility. And this case, as you said, we have to may have anastomosis at around 5 to 4 centimeter. Okay, so in that case, you may have to do if it is very low, you can go a frozen section. Otherwise, there is no need. That's why you have to dissect up to the pelvic floor. That is very important
Yes, sir.
without injuring the posterior wall of the vaginal wall. That's why I said you have to ask your gynecologist to help to lift the uterus while you are dissecting below,
Yes, sir.
because the posterior vaginal wall will be always adherent there. You have to go in the space between the rectovaginal septum. Okay, so
the
while
lower
doing
limit
so
you
only
would
you can go
consider?
there.
What is the lower limit you would consider when you would preserve the sphincters in today's situation?
So lower limits are, I could even plan for endosphincter resection, whether partial or subtotal resection, and do a colon anastomosis. And primary anastomosis. This could still be continence. We could preserve the external anasphincter. But if even the external anasphincter is involved, then we have to proceed with an APR resection or an extra elevator resection and plan for a permanent stoma, sir.
Okay. So in this case, there is no need for, because it is around 7.5 centimeter, there is no sphincter complex involvement. You can put a circular step. Okay, up to that. So you
At
definitely you will
surgery,
go for a diversion stoma. You have to tell it will be temporary one. Okay.
Yes, sir.
So anything else you
at
want to
surgery,
do
what are
before
the
going for
things you will be
surgery?
careful about? What are the
Uh,
structures you will preserve and how?
uh, so as this is a post-radiated field, so there could be possibility for injury to the nerves, and already radiations have shown. Radiated patients have a poor has a high propensity for bladder dysfunction and bladder sexual and LAR syndromes. So we have to take care of the nerves, preserve the nerves. We usually
The
preserve.
site where you will preserve the nerves. What are the sites
I think
you will be careful about them?
One is at the root of IMA, sir. Then while the sacral promontory level, then when we are dissecting along the lateral stalks, and then if it's a male patient, predominantly in the anterior, while it enters into the seminal vesicle, that area, sir. These are the areas in which the nerves have to be specifically look for and preserved, sir. The lateral stalks, when we are dividing, we have to make sure that only the rectal branches are divided and not the maintaining the proper TME plane, which will allow that, sir. Then generally post-irradiated tumors, rectal walls are generally a bit thicker, and as this is an ultra low resection, we have to be careful about how we are handling the distal margin. Will require the articulation is a bit difficult at that level, sir. But generally it is feasible.
Yeah, Raj.
Yeah, in particular, what are the important things in a female patient with a rectal malignancy? If you discuss in the multi-MDT, the gynecologist, they will ask, so this is a 48-year-old
One
lady.
thing is, sir, whether the family is completed.
Yes.
If family is not completed and she wish to preserve ability, whether oocytes has to be banged
No,
or
no, this case, we are discussing about only this
in
case.
this
She is
case,
48.
in this case, as well as a lower rectal malignancy, whether the possibility for infiltration into the vagina, there is a high possibility post-radiated field, the formation of a fistula. Those are the main things. Whether
So will you remove the ovaries in this case or not? Or
uh,
when will you do that case?
So prophylactically removing ovaries is not usually done in our centers, but as is a less than 50-year-old patient, there is a possibility for an HNPCC related disease, but she doesn't have any family history. So if at all she's family is completed and if she's sufficiently motivated, we could advise for a prophylactic oophorectomy. But generally we don't practice it here, sir. Yeah, that's it.
So what the literature says, generally you don't practice what the literature says. In
Sir,
postmenopausal or perimenopausal age with the CA rectum, whether you want to remove the ovary or preserve the ovary, what is the logic
So
behind
removal of
that?
ovary, unless and until it is infiltrated or shows any margin issues, the prophylactic removal is not really recommended as per NCCN guidelines. But as said, if there's a high risk features of high risk family history or any possible familial syndromes, then we could plan for a prophylactic removal. So otherwise, in an otherwise normal patient with CA rectum, I would not be planning for an oophorectomy.
Okay, but there is no evidence if in a postmenopausal woman, if it is a CA rectum, there is what the recent this thing says there is a high possibility there may be a metastasis. So we can remove the ovaries. Okay.
Yes.
And most of the time with the previous surgeries there for this patient or previous LSCS, it is coming along the way, you can remove the ovary as well. Okay. Most of the perimenopausal, postmenopausal. Okay. And of course, if you're thinking of HNPC, definitely you have to remove. Even you have to do the hysterectomy.
Now, for this patient, will you consider adjuvant treatment?
Yes, sir. As I've given only long course chemotherapy for this patient, irrespective of the pathological finding in the final pathology report, I prefer to give an adjuvant treatment. Usually we give at least 6 cycles of Capiox or Folfox depending on the policy, sir, and then follow up the patient, sir.
And regarding stoma closure, when will you close the stoma?
Usually we prefer to close the stoma after 2 cycles of chemotherapy, sir. That depends actually on the pathology report, sir. If it's showing still an aggressive disease, poorly differentiated, we go for a late closure of stoma. But if there is good tumor response, early disease, no much infiltration and no poor differentiation of signal cell, we plan for a early stoma closure, sir. Some patients, especially younger patients, we have even
No, just clarify that. Early stoma, when do you close early stoma? When do you have
only
early-
when the pathology per se, if it is good, sir, or there's a good response and there is no much of and the CRM, everything is normal. In that condition, we plan for we give adjuvant chemo 2 cycles and then plan for closure, sir. But if the pathology per se, if pathology is not good, or if CRM is involved, or there is any poorly differentiated features, then we plan to give the complete adjuvant therapy, then reassess the patient, and then only plan for stoma closure, sir. Because we don't want a break in the adjuvant therapy, sir.
Yeah. Routinely, you would complete the adjuvant treatment and then close the stoma mostly.
Yes, sir. Yes, sir.
That's the.
Okay. I think we have come to the end of this. Majority you have performed well, man. But what you do in your institute, if you talk, that is enough. Okay. And whenever the examiners want something and they are giving a leading question, you catch that question and just go in that path. Okay.
Yes. Yes.
Okay. Otherwise, you have done well.
Yeah.
Thank you, sir.
Panelists, Pradeep.
I think Sonu, you've done well. Sir, before this, there are 2 questions in the Q&A. Raj Pandian or Deepak can
Yes.
take up. Some I think has already done. You answered.
Is this a candidate for TNT? No. Anonymous attender. What are the this patient is not a candidate for TNT. So we have already discussed it's not an ugly tumor. What are the indication of PET-CT in CA rectum? Yes, already discussed. Whenever there is a increased CEA, then you go for a PET-CT. What is the lower limit to consider LAR and sphincter preservation? As depending upon the consultant experience. So whenever you can give a negative frozen section while doing intersphincter resection, yes, in my point of view, I will do post radiotherapy before taking for surgery. I will do a scopy, particularly sigmoidoscopy, and I will assess what is the distance from the dentate line. So, and the MRI, if it is a good response, and if you have a dentate line, from the dentate line, it is less than 2 centimeter, or I can give a clearance of 1 centimeter from the dentate line, yes, I will go for intersphincter resection. That is my limit. Why not TNT and plus or minus wait and watch for her? Already we have given neoadjuvant CTRT. In this case, we will not go for wait and watch, because definitely you can give a complete cure for this patient once you do a ultra low anti-resection. This is a higher tumor. Post MRI, the annual verge is from 7.5 centimeters. So this is not a case for wait and watch. Same patient, if it is like 3 centimeter and if it's a good response, and if a patient is a good candidate for wait and watch, then we can go for then that endoscopy has to show there should not be any only scar, there should not be left behind ulcer, and MRI should go for only fibrosis. Then those are the patients for wait and watch, not this patient.
Yeah. I would just add, like TNT, actually in these patients, we would consider only when there is a threatened CRM, or if there's a MSI high patients. In those patients, if there's a ugly tumor, as Raj said, we consider TNT, especially as the patient is young and has no comorbidities. So we would have a low threshold for going for TNT in this patient if the tumor is not very good. Otherwise, neoadjuvant treatment is good enough. NACRT is good enough in this patient. And as regard PET-CT, I think it's covered. Other things have been covered by Raj. Any other panelists?
Thank you, Dr. Kapoor, Dr. Shastri, Dr. Avinash, Dr. T.D. Yadav. Any comments?
Good morning, Pradeep.
Morning, sir.
Whenever you see a relatively young patient with colorectal, or I would say any other malignancy also, your family history needs to be asked and mentioned in more detail. First and second degree relatives. That tells the examiner that you are thinking of a possible familial background and you have looked into it. Because if there is a positive family history, a strong family history, then your treatment plan may slightly change. All students should remember a few conditions which are very often missed or misdiagnosed. One was already mentioned, that a patient with bleeding per rectum misdiagnosed as hemorrhoids because of per rectal examination, digital rectal examination was not done, and some procedure done for hemorrhoids and CA rectum is missed. Second is a choledochal cyst missed during cholecystectomy. That's a very common presentation of choledochal cyst. Third is an elderly gentleman who presents with acute appendicitis and a carcinoma of the cecum is missed. And last is a periampullary tumor or a tumor in the head of the pancreas, which presents as acute pancreatitis, which is managed conservatively, and then the tumor is missed. So these are some conditions which all students should remember. As far as the clinical differential diagnosis is concerned, if a patient presents with constipation and bleeding, you have to mention and you have to keep hemorrhoids in mind. It is just that we don't see these patients because they go to the physicians, the gastroenterologist. But we have to remember that the commonest cause of bleeding per rectum in the population is hemorrhoids. So, as was pointed out, I think by Dr. Pandian, that you have to say that I will think of hemorrhoids, but keep malignancy at the back of my mind, which means that you will try to find out or rule it out on clinical examination or investigations. And solitary rectal ulcer syndrome also has to be kept in mind, especially in patients who have a long-standing history of chronic non-responsive constipation and history of digital evacuation. If it is a relatively younger patient or a child, you have to keep polyp in mind. And blood in clothes, you said hemorrhoids. I don't think that would be correct. Basically, it indicates that the person is incontinent during sleep. It's a minor incontinence. So if you are thinking of CA rectum, you have to think of whether the sphincter has got involved, which has given rise to minor incontinence, so that there is soiling of clothes at night time. Or if it is, say, prolapse, or if it is history of digital evacuation, then you have to think, or elderly patient, you have to think of inherent weakness of the sphincter. So these are some small minor clinical points. One point which I would like the experts to correct me if I am wrong, short course radiotherapy is only radiotherapy. So please correct me if I am wrong, because the student mentioned short course chemoradiotherapy. I think short course is only radiotherapy.
Yeah.
So students, please send me a mail, bkkapoor.india@gmail.com, write rectum in the subject of the mail. I will be happy to share with you chapters on CA rectum from my books on clinical surgery and operative surgery. Thank you.
Thank you. Dr. Shastri, Dr. TD.
Nothing much. I think is done fairly well and all points are well covered.
Short course, the experts, would you like to comment whether what I said was right?
Short course means
Yeah.
with the only radiotherapy, sir. You are correct, sir.
Yes.
No chemotherapy. Only 5
So
days.
students,
we do
That's
Five
only
yeah, student, you should be very specific. You should say short course radiotherapy and you should say long course chemoradiotherapy.
humor. Yes, you are correct.
The waiting interval after short course, there is a change in thought that earlier we used to operate within 7 to 10 days of short course, but now there is evidence that even after short course, if you wait
You have to
longer,
wait.
the response may be better. So more and more groups are changing to that.
Yes.
Thank you.
With the TNT, a lot of people are changing to short course followed by chemoradiation, but otherwise, a short course alone does not add chemotherapy.
Okay. So you are saying that short course as a part of TNT.
That's right. Sometimes people are.
Okay.
There are
But
studies.
short course also we wait for 6 to 8 weeks, sir. That's correct. And if you are planning for TNT, usually go for long course only.
Yes.
Yeah.
Yes.
And
There are
if it is
studies on
ugly
that
tumors,
aspect.
but some they are given even short course, sir, because in consolidated chemotherapy they are giving like short course.
Okay.
But not what we are following in our center nowadays. We are giving in long course neoadjuvant CTRT. In the waiting period, we are giving a interval chemo 3 cycle. We take up surgery and post-operative we give a 3 cycle adjuvant chemo. And we are having a trial, and TNT only for ugly tumors up to a lower third, where sometimes if it is a good response, you go for a wait and watch policy.
If no more comments, can we wind up, sir?
Yes, sir. Yes, sir. We can. Thank you very much.
Thank you, Sonu. Thank you, Raj Pandian. Thank you, Deepak, and thank you,
Okay.
Radhakrishna. I think yes. Thank you.
Thank you, sir. Thank you.
Thank you.